Good afternoon, everyone. We may still have some more people joining us, but it looks like a lot of people logged in right at noon. I'm Dr. Timothy Ott. I'm the current president of the Illinois Academy of Family Physicians, and it's my pleasure today to moderate a presentation by Dr. Corinne Kohler, who's also an officer of the IAFP, on 2023 adult immunization recommendations. So the IAFP made a decision a number of years ago to support DEI in all of its forms and all of the work that we do. So we'll try to make this as inclusive as possible. Housekeeping for today. All attendings are in listen-only mode, so you cannot activate your microphone. If you have any questions as we're going along, please enter them in the chat feature. And at the appropriate time, I will read the questions to our presenter today for her response. This presentation is being recorded, and all discussions, questions, and answers will be part of that final recording, which will be available to anybody who's in attendance. Accreditation, this is approved for CME by the Illinois Academy of Family Physicians and the ACCME. It's approved for 1 credit hour of AMA PRA Category 1. And it will be an enduring credit on the IAFP website after we're done. The support for this activity is sponsored by the Illinois Department of Public Health through an adult vaccination coverage level grant. Thank you and enjoy the presentation. In order to receive the CME credit, you must complete the post-test and evaluation. That website link will be available for you, and it will also be emailed to you at the conclusion of the webinar. Disclosure, we do have a conflict of interest policy. Dr. Kohler and myself and Kate Valentine, our IAFP staff, who's sort of running things behind the scenes for us, all disclose no relevant financial relationship or interest with any vaccine or marketing service. Here we go. Dr. Kohler should be coming on with her slides, and there we go.
Okay, hopefully you can see my slides, and I'm now unmuted. Good afternoon, this is Dr. Corinne Kohler. I'm very pleased to be with you. Thank you, Dr. Ott, for your kind introduction. We're going to talk about the 2023 adult immunization recommendations. There is a lot of information here, so if you have questions, please feel free to enter them into chat or send them to us later, and I'm glad to also answer anything offline. Our learning objectives for today are understanding the CDC adult immunization recommendations, including special populations, identify strategies to increase vaccine rates in your community and practice, including standardizing office procedures, learning the different vaccine types, and evaluating the safety and efficacy of adult vaccines. Adult immunizations is an important aspect of preventive health care and has several benefits, including protection against infectious diseases, prevention of disease spread, reduced healthcare burden, cost-effective, improved quality of life, safe and effective. Overall, adult immunization is an important public health strategy that can help prevent individuals, communities, and the public at large from the spread of infectious diseases, while also providing significant health and economic benefits. Those of us in family medicine understand that adults are also the vector many times for pediatric and childhood illnesses. Let's talk just a little bit about the immune system. The function of the immune system is the body's defense against infections and disease-causing pathogens. Components of the immune system include white blood cells, lymph nodes, spleen, bone marrow, and antibodies. The immune system functions to recognize and respond to foreign substances such as bacteria, viruses, fungi, and eliminate them from the body. And That would include things like physical barriers such as skin, hair, and mucous membranes. We would call that type of immunity innate immunity. Innate immunity is the first line of defense of the immune system that provides a non-specific response against pathogens using physical, again, such as skin, hair, and chemical barriers such as mucous membranes, as well as immune cells that detect and eliminate them. It is present from birth and doesn't differentiate between different types of pathogens. Acquired immunity is a defense mechanism developed by the body over time after exposure to various pathogens or through vaccination. It involves the production of antibodies and specialized immune cells that specifically recognize and target particular pathogens, providing a tailored response to future infections. And basically, there's two when we talk about acquired immunity, we have immunity that develops during your lifetime. So there's active immunity that develops in response to an infection or vaccination, or passive immunity that develops after you receive antibodies from someone or somewhere else. Natural, under each type, there's natural and artificial immunities. Talk about those. So, talking about active immunity is a form of immunity that results from the body's own immune system responding to an infection or vaccination. This type of immunity involves the production of specific antibodies and immune cells, providing long-lasting protection against future infections from the same pathogen. So this is, again, very pathogen specific. Whoops. So under active immunity, you have natural, which are antibodies developed in response to an actual infection, or artificial. This is what we develop in response to a vaccination. And just remembering, antibodies are very disease specific. For example, measles antibody will protect against a person who's exposed to measles, but not necessarily if they're exposed to something else. Okay, so let's talk a little bit about what is a vaccine. Sorry. Okay, so a vaccine is a preparation that is used to stimulate the body's immune response against diseases. Vaccines are usually administered through needle injections, but they can also be administered by mouth or sprayed into the nose. Examples of that would be like the nasal flu vaccine, or by mouth would be an oral polio vaccine. So there's some different types of vaccines, and I thought we'd just do a review of those this afternoon. There's inactivated vaccines, live-attenuated vaccines, messenger or mRNA vaccines, subunit recombinant polysaccharide and conjugate vaccines, toxoid vaccines, and viral vector vaccines. So inactivated vaccines. Inactivated vaccines use a killed version of the germ or bacteria that causes the disease. Inactivated vaccines usually don't provide long-lasting protections that's as strong as live vaccines, and after your primary series, you may require booster doses over time in order to keep ongoing immunity. And examples of those would be hepatitis A, influenza, and polio, both the injectable forms, not the oral forms, or rabies. Live attenuated vaccines. So these are live vaccines that use a weakened or attenuated form of the germ that causes a disease. Because these vaccines are so similar to the natural infection that they help prevent, they create a strong and longer lasting immune response. And usually just 1 or 2 doses of most live vaccines can give you a lifetime of protection against a germ and the disease it causes. There are some limitations to live attenuated vaccines because they contain a small amount of the weakened live virus. Some people should talk to their healthcare provider before receiving them, such as people with weakened immune systems, long-term health problems, or people who had an organ transplant. This could also include pregnancy and preconceptual counseling. They need to be kept cool so they do not travel well, which means that they are often limited use in countries that have limitation to refrigerators or things like mass vaccine activities. Examples of some live vaccines would be MMR, your measles, mumps, and rubella, rotavirus, smallpox, which hopefully we don't see, chickenpox, yellow fever, which again would not be common to our population, but might be in some of your travelers. mRNA or messenger RNA vaccines, and researchers have actually been studying working with mRNA vaccines for decades, even though it feels like it's just been in the media the last few years. And this technology has been used to make some of the COVID-19 vaccines, and certainly has been worked on for many of the corona vaccines, both in the past and currently. mRNA vaccines make proteins in order to trigger an immune response. The vaccines have several benefits compared to other types of vaccines, including a shorter manufacturing time, and because they do not contain a live virus, there is no risk of causing disease in the person getting vaccinated. And right now we're using mRNA vaccine for COVID-19. Okay, subunit recombinant polysaccharide conjugate vaccines all use specific pieces of the germ, like its protein, sugar, or its capsule. Because of this, they give a very strong immune response that's targeted to key parts of the germ. They can also be used on almost everyone who needs them, including people with weakened immune systems and long-term health problems. One limitation of these vaccines is, again, you may need booster shots in order to keep going with lifelong or long-term protection. Okay, so some examples of some of these would be your HIB, your Haemophilus influenza vaccine, hepatitis B, your HPV vaccine, your pertussis or whooping cough component of the DTaP, pneumococcal vaccine, meningococcal vaccine, and shingles or zoster vaccine. Finally, toxoid vaccines. Toxoid vaccines use a toxin, which is produced by the germ that actually often is what induces the symptoms of your disease. So using the toxoid or toxin creates an immunity to that part of the germ that causes the disease instead of the germ itself. The immune response is targeted to the toxin instead of the whole germ. Like some other types of vaccines, you may need booster shots to get ongoing protection against diseases. And examples of this would be the diphtheria and tetanus, which I think we're all familiar with. Okay. Vector vaccines. And for decades, scientists have studied viral vector vaccines. And again, these pretty much are limited to viral infections. Some vaccines recently used for Ebola outbreaks have used viral vector technology, and a number of studies have focused on viral vector vaccines against other infectious diseases such as Zika, influenza, and HIV. Scientists are using this technology to make COVID vaccines as well. Viral vector vaccines use a modified version of a different virus as a vector, and several different viruses have been used as vectors, the most common of which is adenovirus or the common cold virus, although there are others. And adenovirus is the one that is currently being studied in clinical trials. Recently, there have been studies ongoing for Ebola and some of the other viruses also, but currently COVID-19 is what you'll see as an emerging vector vaccine. Okay, so let's shift and actually talk to what is recommended for adults. Now, many of these vaccines, your patients, clients will have received childhood primary series. They may need boosters. They may not have completed primary series, but many of these are ones that adults are eligible for, but they may have already be up to date. But we're going to go through the ones for adults. This is the current list of CDC adult recommended vaccines, and it is up to 14, which is actually quite a bit. So we're going to start recommended for all adults ages 19 above. And of course, I'm going to start with COVID-19 vaccine. And as you all know, the COVID vaccine has been changing. In fact, ACCME is meeting today. FDA met yesterday and actually did the approval on the 2 Pfizer and Moderna vaccines. and has published a very nice paper, which I'm going to ask Kate eventually to send a link to, with the current updated recommendations. These will also be on the Illinois Vaccinates or IVAC website on what will be released for the fall vaccines. But certainly the underlying message is all adults should be receiving their COVID-19 vaccination. If they have not received it previously and they need a primary series, currently it's 2 doses based on the brand. And of course, the booster dose that will be recommended this fall. For adults that are moderately severely immunocompromised, there is a different vaccine schedule. Again, referring to CDC or the Illinois Vaccinates is your best way to ensure that you are ensuring the optimization on this particular vaccine, since the landscape on this changes quite frequently. Moving on to influenza vaccine, we are in the season, which typically in the Northern Hemisphere is fall and winter. It is a yearly vaccine. We know it as a flu shot. It helps to prevent against serious illness, hospitalization, and death against influenza. It may not totally protect against getting an influenza illness, but as we know, again, similar to the COVID, it will help prevent that serious disease. Typically, there's A and B combined in an influenza vaccine. It's determined in the spring what the formulation will be each fall, as influenza virus itself is one that highly mutates. But since we're aware that influenza is highly contagious, that can cause serious complications, especially in younger children, older adults, and people with immune systems, we want to make sure that all eligible adults do get vaccinated. And again, adults are often a vector for those very young infants that cannot be vaccinated before 6 months. It would be considered a routine vaccine for anyone 19 years or older, 1 dose yearly. For those older adults, 65 years, there is a quadrivalent formulation. If that is available, that is what is recommended. If it's not available, any trivalent vaccine would be recommended. We didn't specifically address a live vaccine because it has limited availability, usually just through age 49, and would not be recommended any contact or individual that is pregnant or immunocompromised. For those special situations such as egg allergies, if someone tells you they are allergic to eggs and only have hives or something very mild, in other words, they can't eat raw eggs but can eat cooked eggs, such like that, then pretty much any influenza vaccine is considered appropriate at this point. If they have an egg allergy that's more severe than just hives, then it would be recommended that they receive that vaccine in a medical office that is prepared for any kind of a vaccine emergency. And again, any age-appropriate formulation is acceptable, even though there are some egg block formulations, as long as it's being administered in an appropriate situation. So this would not be someone I would recommend getting at the pharmacy or drive-through clinic. This is someone that should be receiving it in a medical office. For a more severe allergy, such as anaphylaxis, those definitely require shared decision-making. I would recommend having them be seen by an allergist who can actually determine whether or not they can get an influenza vaccine. Anyone who has close contact for severely immunized, immunosuppressed patients should definitely get a vaccine, but should not be getting the live viral vaccine. And again, needs to make sure they take appropriate precautions. Influenza vaccine is highly recommended for our pregnant population. Any stage of pregnancy, it does provide some protection for that newborn and breastfeeding infant. Moving on, hepatitis A vaccine, many of our children are getting this when they're younger. Again, if you have a non-immunized population, They can consider this. Hepatitis A vaccine used to prevent hepatitis A, which primarily affects the liver. It's spread through contaminated food or water or through close contact with an infected person and can cause general symptoms. Hepatitis A vaccine contains a part of the virus that stimulates the immune system to produce antibodies against it, providing protection against hepatitis A. Routine vaccination, those who have not received a primary series still want protection, certainly I would be not contraindicated to any adult that is requesting it. It is basically a 2-dose series unless it's combined with the hepatitis B. There are some special situations, certainly if you have somebody that is unknown or unimmunized status and they're a daycare worker or a healthcare worker, they're at risk for hepatitis A for any reason: chronic liver disease, HIV, drug use, non-housed individuals, anybody that works with hepatitis A or similar vaccines, travel, and they say high or intermediate endemic, but honestly, any travel to a developing country, contact with international adoptees, because again, they may be carriers, and settings for exposure, and that would again be your daycare, healthcare workers, anyone that's in close living contacts, even residential, such as dorm living, any close contacts or food and water contamination could occur. Hepatitis B vaccine, again, hepatitis B affects the liver. This virus is primarily spread through infected blood or other bodily fluids, can lead to serious liver disease and liver cancer. And again, hepatitis B is an inactivated vaccine. It contains a part of the virus that stimulates the immune system to produce the antibodies. Most of our children are receiving this as a primary part of their childhood series, but again, if you have unvaccinated adults, it is routine recommended for anyone up through age 59. That is the current recommendation for hepatitis B. For age 16 older, if they have no risk factors, then definitely I recommend completing that series. If they just would desire immunization or unsure, again, there's no major contraindications to this vaccine. It is considered a 2-dose series. If it's combined with Hep A, it would be a 3-dose series. For patients that are on dialysis, it is a slightly different series. It's either 3 or 4-dose, and there is a dialysis formulation. And again, you probably would be referring those patients to a specialist or be looking up that information for any of those patients. Polio vaccine. So polio vaccination is a vaccine that helps protect against poliomyelitis. Also, we know it is polio, highly infectious, although we commonly don't see it in this country. It is still worldwide in developing countries. It can cause permanent paralysis, primarily affects children under the age of 5. But again, your adults can be a great vector for this. There are 2 types of pneumococcal vaccines, typically the inactivated and the oral. Most developed countries are using the inactivated. In developing countries, you'll see the oral polio vaccine given, and that does offer some GI and actual protection against the live virus. The oral polio vaccine is a live-attenuated viral vaccine, so should not, again, be given to pregnant women, immunocompromised individuals. But in this country, you're going to pretty much be limited to inactivated polio vaccine, although you may see vaccine records that contain oral. It is a 3-dose primary series. Okay. Tetanus, diphtheria, and pertussis. We see this commonly called Tdap or DTaP in the pediatric population. It's a combination vaccine that helps protect against 3 different diseases of tetanus, diphtheria, and whooping cough. And again, while whooping cough is often serious illness in a child, can also be serious illness in our older adults, and again, they can be vectors. These 3 usually come combined together, and there are different formulations based on pediatric and an adult. The adult age 11 and above is usually called the Tdap vaccine. For anyone that did not receive one after age 11, they would receive that as a primary vaccine. It generally is repeated every 10 years, either as a whole Tdap or just as a TD if they are not needing the pertussis component. The pertussis component really is recommended for most adults. So most of the time, I think we are giving Tdap. If anyone did not receive the primary vaccine series or is unsure, then doing a booster is always a good way to proceed. Pregnancy, Tdap is recommended. Every pregnant woman, every pregnancy above 28 weeks, it does offer protection to the newborn and for breastfeeding. And of course, any dirty or at-risk wounds with unknown status would receive tetanus. And again, either formulation for tetanus protection is acceptable. We typically will do a booster every 10 years for those that need ongoing protection, such as daycare workers and healthcare workers. Varicella or chickenpox vaccine is a vaccination against varicella zoster virus. It is a virus that causes chickenpox. This vaccine, again, is typically given to our children, but adults who have not had or are unaware of chickenpox may also receive the vaccine. There is possible to do a titer for varicella to check immunity. And based on the patient's situation, insurance, and cost status, it may be cost effective to do the titer, or it may be cost effective just to give the varicella vaccine. And that would be a shared decision making. Would we recommend it in any preconception counseling that varicella titer be checked along with your measles, mumps, and rubella, which we'll talk about in a moment. This virus does contain a weakened form of the vaccine does contain a weakened form of the virus that stimulates the immune system to produce the antibodies that can protect. So again, it is a live virus vaccine, so you do not want to give it to actual pregnant women or those that are, compromised. Anyone that has received no evidence of immunity or has a low titer would be eligible. Again, preconception for pregnancy or immediately postpartum, but not actually during pregnancy, especially not during first trimester. Healthcare workers definitely should have either a positive titer or a vaccine. HIV infections with CD counts over 200 or over 15% can receive the vaccine. If they're lower, again, that would be shared decision making along with severe immunocompromised conditions. Moving on to our young adults, this is primarily the 19 to under 60 population, a couple of vaccines specifically for this age population. So meningococcal vaccine, again, most of our young people will be receiving this through their school vaccines. Typically the MNACY in the state of Illinois is received at that 11-year-old visit in a booster above age 16. After about, as an adult, it's generally not necessarily given. There's also the meningitis B vaccine that I'll mention in a moment. So for the MNACY vaccine, anybody that's asplenic, either through something like sickle cell, HIV infection, trauma, whatever, should definitely be receiving the meningococcal vaccine. If you're traveling in countries that are endemic, you should receive it. Anybody that's working or exposed to the vaccine, those that will be living in close living quarters, and this might be your dorm students, these could be military recruits, this could be your prison population, those that are even shelters, from when we have shelter living after a natural catastrophe like a hurricane, any of those should probably be receiving 1 dose of MNACY. Specifically for the meningococcal vaccines, that's typically 16 to 20 recommended 2-dose series for those that, again, are going to be in your close living situations. So if you're seeing those young adults and they're requesting it, there's really no contraindications in that age group, and that may be a recommendation if they are in one of those high-risk groups. HPV vaccine has been around for a while. Many of our young people have been vaccinated. With that, it's a vaccine that can help prevent against certain strains of the HPV virus, including several types of cancer and genital warts. Typically, it's recommended for all ages, all individuals through age 26. The recommendation is a first dose between 9 through age 14. As long as the first dose is received before their 15th birthday, it is a 2-dose series. So whether it's a 2 or a 3 dose depends on the age and initial vaccination. If you're seeing your adults, if they've had 1 dose before age 15 but never received the second, you do not restart. You just complete the series. If they've had both doses, then they do not need any additional dosing. If they're starting the series at 15 or above, then it is a 3-dose series. And again, you don't need to restart the series even if the vaccine schedule is interrupted. So up 9 through 26 is the recommendation on the age range. There's approval for up through 27 through 45 with shared clinical decision making if you're in a high risk group. And this would basically, again, be your individuals that are exposed to drug use, multiple sexual partners, and such like that. Highly recommended. We have good evidence-based data showing HPV vaccine has reduced cancer in both men and women for those high-risk cancers. Okay, let's talk about the 60 and above and then some special population. I'm going to start with RSV, our newest vaccine on the market, released on June 21st. We're just starting to get a lot of that data out to the public. You'll start seeing advertisements, basically 60 and above for a single dose using shared clinical decision making, meaning that at-risk populations, that would be your COPD, your asthma, your immunocompromised, anything that makes you at higher risk of developing RSV. I would also include that, again, adults are a strong vector for those children for RSV. So anybody that's a daycare worker, anybody that is around a small infant may want to consider RSV. So far in the pre-marketing data, the side effect risk profile has been very low, and that information is on the CDC website. It has demonstrated moderate to high efficacy in preventing that RSV-associated lower respiratory tract disease. Again, risk of severe illness, risk of hospitalization, reduced risk of death, potential to prevent substantial morbidity and mortality. Obviously, there'll be a lot of post-marketing surveillance done, but right now it is recommended as a single dose. Whether there'll be boosters in the future, hopefully we will be determining this. This can be given with at the same time you're receiving your influenza or COVID booster, and it is something that I think we all have to individually make the decision how strongly to recommend this to patients, but it is coming out strongly from CDC and ACIP that this be offered to our population of 60 and above. Okay, moving on, pneumococcal vaccine. Okay, in my life, this is one of the more confusing vaccines to understand the vaccination schedule for an adult. It's a primary series that's a child. It's a vaccine that's recommended, again, age 65 and above. There's a number of different formulations, PCV 13, 15, 20, the polysaccharide vaccine, 23. It helps prevent against pneumococcal disease, which is caused by strep pneumoniae bacteria. Pneumococcal disease can cause a wide range of illnesses, including pneumonia, meningitis, sepsis, particularly serious in young children, older adults, and people with weakened immune systems. The thing about pneumococcal vaccine, age 65 years and older, and you need to assess on an individual patient whether they've had the primary, whether they've had PCV13, whether they've had 15, if they've received the 20, which has been out just over the last couple of years. There is a very good mobile app called Pneumo app. Very easy, very quick to use. I used it in clinic. That tells you plug in what they need. And also you can go to CDC. Basically, if you're unsure what they've had, or they haven't received one of the 20, you're going to give them a PCV 20. If they've depending on if they've received one of the others, there may be an interval in receiving that. Again, age 19 to 64 with underlying medical conditions. This would include things like patients going through chemotherapy, immunocompromised patients, anyone who do not know the previous vaccination history, if they've only received one of the pneumococcal components, or if they've received the polysaccharide 23 and it's before age 65, then you would complete the series with the 20. And again, I'm going to refer you to that app. We can, the link should be in your notes. It's a great way to assess the pneumococcal vaccine. Zoster vaccine or shingles vaccine. It's a vaccine used to prevent shingles, often painful, often debilitating by the reactivation of varicella zoster. I think we've all had patients that have come in with shingles who tell us they've never had chickenpox, but now they have shingles. So sometimes that virus is present and we aren't even aware that we've been exposed. This vaccine contains a weakened form of the virus that stimulates the immune system against the virus, actively providing protection against that reactivation against shingles. Of note, shingles vaccine is not 100% effective. However, it does help prevent that serious debilitating disease, limits the time of illness, so less severe, shorter in duration. So therefore, it is recommended. I'm going to go back for just a moment on that. For those of us in practice for a while, we will all relate on adults that have had this vaccine versus those that have not, and definitely can see an improvement of vaccine. The initial vaccine, Zostavax, was a single dose vaccine. Currently, what we're using now is branded vaccine Shingrix, which is a 2-dose recombinant vaccine given basically 2 months apart. If the second dose is given too soon, you do have to repeat that dose, but otherwise it is a 2-dose series. And again, it's considered kind of a live vaccine. It's also not generally age appropriate in a pregnant population. Immunocompromising conditions, you do want to have talk with your healthcare provider and consider that individual situation. I will say this is one vaccine that I really talk with my patients about. I strongly recommend it. I would not get this vaccine within a couple of days of anything that would be considered a major event. This is a vaccine that typically does have some side effects. Sore arm, lethargy, mild fever, 48 to 72 hours. So this is one vaccine I do warn my patients about ahead time that they may get some side effects. So don't plan any major events within 2 to 3 days of the vaccine. They may get with dose 1, they may get with dose 2. They may get with both doses, or they may be one of the fortunate ones that really does not. And then they come back and tell me I was wrong. And I'm so happy to be wrong in that situation. But I do actually do a fair amount of counseling with the shingle vaccine. This one typically for your Medicare patients also needs to be given at the pharmacy or check their insurance status, because depending on what their insurance status is, it can be fairly costly if not covered. Okay, moving on to a couple other special situations. Haemophilus influenza or type B vaccine. Again, basically, this is one that they should receive as an infant, but it also can be used in adult population special situations. It's a vaccine used to prevent bacteria caused by Haemophilus influenza, meningitis, pneumonia, bloodstream infections with that. Typically, patients that are asplenic, anatomically or functional, whether it's sickle cell, immunocompromised, should receive a dose of Hib. If it's elective splenectomy, ideally you want it at least 14 days beforehand, but in those situations where it's not elective, it is recommended. For someone who's having a hematopoietic stem cell transplant, it's a 3-dose series, 4 weeks apart, starting 6 to 12 months after transplant, regardless of previous vaccination history. So again, that history of whether or not they could possibly be, be asplenic is important to know in your adults. And this is one that you would want to check on. MMR vaccine, again, typically given in childhood, but you may have individuals who would either have not received the primary series, especially if we're seeing that refugee or immigrant population, also perhaps waning immunity. This helps protect against measles, mumps, and rubella, and it is combined with all three. So this is something that a titer can be done. So especially preconceptual counseling, pregnant women, we're going to make sure we do rubella titers. Now it's also recommended mumps titers. We have always done all three of them in the clinic. If they're eligible for the vaccine, and if one titer is low and say they're low in rubella, but measles and mumps are fine, you still would want to give the vaccine to the appropriate eligible individual. So again, if there's no immunity to any of the three, you would give a single dose vaccine. You do not give it during pregnancy, but preconception, postpartum, catchment population. And again, you would want to do a rubella titer every pregnancy to check for that immunity status. And anyone in a household, anyone around small children, again, I would recommend titers, especially for the rubella, but it's easy. You can actually obtain titers from all three of those components. Again, some special situations with measles, mumps, and rubella. If they have an HIV and no evidence of immunity, you can give that because it is a live viral vaccine. You want to be careful if they have a low CD4 count, severe immunocompromised individuals, those living in a household of severe immunocompromised individuals, including chemotherapy. You would want to talk with the medical provider. And another population that you would want to make sure is vaccinated appropriately would be those living in close housing situations. Okay, so that covers pretty much the 14 recommendations by CDC. CDC has some great resources on their handout. You can just put in that, you can put CDC, go to vaccines, vaccine.org, immunize.org. All those will kind of take you to those recommendations. They put this out. This is the recommended vaccines. This one happens to be alphabetical. And they go through every vaccine, the special situations, shared clinical decision-making. You can see on this influenza vaccine, all the recommendations about the special egg allergies are on there. So each one is listed out for meningitis. They have the meningitis B separate out from the meningitis ACY on there. Note that's alphabetical. They also have it in this format where it's just listed, and this also gives you the VAERS information and how to report any concerns or severe reactions. This one is just printed differently, color coded. It's what many of us use in our office. It gives you easily to see by age what's appropriate. And this one is by medical conditions such as pregnancy, HIV, and what is contraindicated. So under pregnancy, you can see the live vaccines are contraindicated, but maybe these other ones would be given in special situations with that. And again, your appendix giving all the different vaccines, it gives you your resources and such like that. I would like to take a few minutes to talk about iCare, which is our vaccine registry. iCare is designed to help healthcare providers record, track, and report their patients' immunizations. This registry is really helpful for improving your vaccination rates in your office, helping just take care of those adult population, helping them to be knowledgeable with what vaccines they may be eligible for or recommended. The registry allows physicians to access patient records for information about immunizations, not only administered within their practice, but outside their practices. Participation is voluntary, except if you're a VFC provider, and those of us that are doing pediatrics already know this, or if you're administering the COVID-19 as provided by the government, in those cases, you must be part of iCare. But if you're just doing adult immunizations, you do no VFC, or if you're a practice that doesn't do any immunizations, but certainly you're giving vaccine recommendations to your patients, you're not required to have iCare, but certainly would be strongly recommended. This is a tool that can really be helpful in your practice. So the advantages allows you to access immunization records. If it's entered, you can see it. You can import the vaccine records into your most EMRs, and many of the EMRs now have what are called bidirectional interfaces. So if I give the vaccine in my office, it automatically downloads into iCare. It does not have to be manually entered. If I have somebody coming in, say from another state, and they bring me those vaccine records, again, if I enter it into my EMR, it automatically loads into iCare. If you're not lucky enough to have a bidirectional interface, you just load them straight into the iCare. It's fairly straightforward. But again, you can see all those vaccines that have either been given in the state of Illinois or have been imported into the registry. And so not only checking vaccine status, if you need to print it out, if they need documentation, it's very helpful. There's a number of reports that are available with iCare. You can set them up. You can use this to help schedule your annual flu vaccine, to help boosters. You can really use it to boost that vaccination rate outside of your office. One of the times that I used iCare a lot was in the early days of HPV, when we were trying to capture that population, maybe didn't routinely get them at that 6th grade physical. So that 13, 14, not yet 15-year-old, we used the report function to capture those and to get them into the office, and definitely a value to that. Anyone that's works for a clinic, but the medical director or whoever your supervising individual is has to give approval to access. They are a little tight on their security, so you have to have actually worked for a clinic for at least a month in order to have your own individual iCare. And you as an individual has your own iCare access. There are not shared sign-ons with iCare. It's you as an individual. You do have to register through the IDPH web portal. And there is good help information. So again, if you're interested, IDPH, you can just go to the portal. Anyone from IAFP office can help direct you, or anyone from your local public health office would also be able to help direct you to the iCare. I strongly would encourage anyone that does not have that in their office, even if you're just using it for record keeping, because you don't give vaccines, it is worth it. I am at this point going to ask Dr. Ott if he would share questions. It looks like there might be some that are in the chat.
Yes, thank you, Dr. Corinne. Wonderful presentation. The first one is Dr. Jacob Varney says that he thinks that they recently updated the egg allergy rule and that there's no precautions necessary. I thought the same thing when you were speaking, and he put links to the information that says there's no specific needs necessary into the chat. So that's available for anybody has questions about egg allergy.
And I think going forward, I guess maybe it wasn't clear. If they have anaphylaxis, I think I still would definitely strongly recommend being careful with it. But yes, just hives or anything that isn't a strong allergy, yes, now it's open. And I think that's definitely an improvement. So, okay.
Yeah, I would agree. If they have an anaphylactic reaction, I want them to sit in my waiting room for 20 minutes, if they have a history of anaphylaxis to eggs, but supposedly there's not any significant reaction.
Yes.
The second question is a little more complicated. Rebecca Levine, I guess, is asking, are RSV vaccines available in most clinics?
My understanding is from listening to a Pfizer presentation is that they will actually be in the pharmacies first. And then because it's a commercial vaccine, it's going to be up to an individual practice whether or not they are going to carry it. Now, the Medicare website does list this as a quote covered vaccine, but again, depending on your Medicare Advantage plan or not having a plan, many of those vaccines have better benefits given in the pharmacy than in the office. But will they be available to clinics and clinicians? Yes, that is what the manufacturers are saying. Again, don't know the ordering quantity. You'd have to go directly to Pfizer and their competitor.
Thank you. I work for an FQHC, and I know we're not going to stock it, but that it is available in pharmacies and at the health department here in Adams County.
I would agree. That is a side note, just as a practice. Again, having worked for an FQHC, many vaccines we're in the process, we recommend, but we do not actually administer. We're helping our patients with education, making them aware of the need, and also helping to direct them to the pharmacy. And I will say, as a side note, if I actually send that vaccine as a prescription to the pharmacy, that can often be beneficial rather than just telling the patient to ask for it. Okay, go ahead with the next one.
Yeah, the next question from Dr. Levine is for pregnant patients who are not immune to measles, mumps, or rubella and get an MMR vaccine after delivery. Do they need repeat titers to confirm that they are immune? If so, when?
Okay, so the short answer is no. They should be immune, and we don't normally recommend titers. But if they have a future pregnancy or they plan a future pregnancy, I would recommend all women who are planning pregnancy to get a titer. And certainly that is generally drawn with the routine first prenatal labs, at least a rubella and mumps titer. So that would be checked again. But just for routine, no, they do not need to get titer drawn.
Okay, and then the last question that I have at the moment is any tips on getting Shingrix covered for patients? Do written prescriptions help? Coupons, other tips?
My understanding is CMS has updated what they should be covering is Zoster or Shingrix is on that list, but again, it's going to depend on your individual coverage. So I think if you don't have an Advantage plan, you probably have a significant copay. My recommendation is because it's almost never an emergent vaccine, that you check before you agree to it, number one. Number two, pharmacy. Typically, almost all my patients, both from the practical side for family members, including my own, versus being a provider, is that most of the time the pharmacy coverage is better than receiving it in the office. But again, if you have commercial health insurance or Medicare Advantage, they may allow you to get it in the office. But please check the coverage first. That's all. That's the best answer I can give on that.
Yeah, because Shingrix can run about $200 per dose. If from what
So this
I'm told.
time I priced it. And so yes, it can be typically not something you're going to be seeing given by a public health department or something like that. There are, but again, check with your check on your insurance and check on the cost before receiving it. Any clinic that has like a wellness coordinator or anything should be able to help you with that. And the pharmacy certainly can run it through their system before they administer it.
Okay, another question just popped up, Dr. Kohler. It may be beyond the scope of your presentation today, but Dr. Montepoli asks, how do you approach adult vaccination prior to travel?
Oh, quickly I will do that, and she wants to send that to me separately. So many places do have travel clinics. CDC actually has excellent recommendations. If you go to CDC under vaccinations and put in where they're going to travel, they will tell you whether it's an endemic area to like meningococcal and such like that. But typically, if someone is traveling, and I'm assuming we're talking outside the United States, hepatitis A, for sure. Hepatitis B, most likely updated meningococcal, and definitely tetanus. So definitely Hep A, definitely tetanus. Hep B and meningococcal if indicated. The one thing I'd say about Hep A is it's a 6-dose series. So sometimes we don't plan that far ahead. If you're traveling and I'm leaving next week to go to Kenya and I've never had hepatitis A, I'm still going to get that first dose before I go, because last research I did is it's about 80% protective on that first dose. Yes, I'm going to complete the series 6 months from now if I never plan to travel again. And again, check CDC website, check with your local travel clinic if you need, because there are some special times that you do for other special vaccines.
Yeah, I've used that CDC website at times and I've found it wonderful.
Yes.
And then there's a big thank you for your excellent presentation. And I think with that, we will respect everybody's time and close the presentation for today. Thank you all for coming.
Thank you.